Well, in respect to those who are also watching us from other sites, we will go ahead and get started. Do we know that we're, if you can hear me, nod your hand. All right, excellent. Okay, so today we're going to talk about cardiomyopathies. And cardiomyopathies basically means a disease of the heart muscle. So obviously, whenever the muscle of the heart gets in trouble, we can say the person has a cardiomyopathy because that's what it means. So you can imagine it's a very, very long list of conditions where the muscle of the heart doesn't do well. And we're not going to probably cover everything today because the most common cardiomyopathy that we see every day is coronary artery disease that affects the muscle of the heart, either by ischemia, by, if we believe in hibernation, or by scarring from a heart attack. And that particular entity is not going to be covered today because we have covered it in many other times. So we're going to be basically talking mostly of the non-ischemic forms of diseases of the heart muscle. And there are many ways to classify them. There is not a single perfect classification for this. This is very simple classification. You have a big heart that doesn't contract very well, that falls on what we call dilated non-ischemic cardiomyopathy. If you have a heart that is thickened or appears thickened, and it is not due to hypertension or aortic stenosis, we call it hypertrophic cardiomyopathy. And then there are all kinds of different other subtypes that could fall in that. If the heart muscle is being infiltrated by some alien coming in there and doing harm, most common one we all see is amyloid. We call it infiltrative cardiomyopathy. And then we have a wastebasket of others that don't particularly fall into any of those specific categories. So when we look at the dilated, as I said earlier, most common one we see is ischemic or coronary disease. And the only thing I'm going to talk about that today in ischemic is that there is an entity that was called ischemic cardiomyopathy in the 50s. Today, anybody that has heart disease, previous MI, and EF of 30%, we tend to call them ischemic cardiomyopathy. But the initial use of that term was in the 50s, at a time when patients were presenting with heart failure, no Q waves in the EKG, in their EKG, any previous infarction. Remember, those days we did not have coronary angiography. These people had a bad dilated use of that term. They have bad CAD, and their EKGs do not show classic Q waves of previous infarctions, and they have a dilated heart with a bad EF. So that was the very initial use of the term. Now we kind of throw it very generally for anybody that has a bad EF and has coronary disease, but that's just for interest how it first came up. Now, these other ones we are all familiar with. We see them commonly. Idiopathic means we have done everything we could, and we just cannot find a cause. Alcoholic is whenever we can, but we do know that these people frequently, they stop drinking, they get good medicines. In 6 months, they have a decent chance of recovery. Familiar hereditary, there's a long list of those. I'm putting here LV non-compaction mostly because it has a more typical echocardiographic appearance. But there's a whole list of genes that can produce, and that's why it's so important of myocarditis. That's another helpful. But myocarditis, and in every heart failure clinic, that discussion goes on in terms of what kind of workup to do. And then we have an interesting group of sort of acute things like sepsis, for example, uremia, vasculitis, lupus. All of them can acutely produce a lowering of EF and heart failure, and then if the major illness gets treated, they can recover. And of course, HIV being another one. So LV non-compaction will simply take a minute or two to talk about it, just because that one that's an etiology that we can suspect by the appearance of the echocardiogram. when you have all of these areas here with these crevices here. So we have extensive spongy transformation because it looks like a sponge, which resembles fetal myocardium. And these coarse trabeculations and deep recesses is what we see right here, that there. Oops. Okay. Previews. Yeah. So these are the recesses we're talking about. 2 layers of endocardium, twice as thick as the epicardium, and you like to see 45% or more of the LV endocardium with this non-compaction. Okay. This is a very great case. I mean, this one would have no doubts about it. And these things do not communicate with blood vessels. Now, it's not always that easy. For example, here in a parasternal view, you will not suspect much, but here now you're clearly beginning to see all those little deep recesses here. And this is an example where the short axis can be very helpful. So as you go closer to the apex here with a short axis, now you see a lot better all those crevices and deep recesses. Another example, you can see that they all can vary a little bit in their appearance. And there are times when contrast can be very helpful. So this is one, an echo. There's a lot of foreshortening here. You can see how small that how short the long axis looks because it's foreshortened. Maybe a little suspicion here, but not much. However, when the contrast was given, it became a lot more apparent that you had all those crevices and the evidence of non-compaction. So there are times when the contrast can be very helpful, and there are many times that, as you can see, this is a delicate finding in terms of echogenicity. So if you have a difficult patient, difficult window, quite frequently we could miss it. And again, this is an area where cardiac MRI can give you very diagnostic and beautiful pictures. Now, this is an example of a 45-year-old man that has heart failure, relatively acute onset, and just has a big, bad-looking heart. So at this point in time, there's nothing in this echo that will help us with an etiology. And that's where history comes in, right? So this guy has a positive HIV, has a low 4CD count, and he has actually AIDS. And this is AIDS cardiomyopathy, has been described now for quite some time. And it's an interesting entity also. He was diagnosed 5 years ago, and he was actually receiving intensive medication at the time that he presented with this. And it's a low incidence, comes in varying degrees of LV dysfunction, and important thing is that it is a marker for higher mortality from the basic disease. I mean, it pushes the patient at a higher level of risk for their illness and for survival. And then there's still mechanisms being looked at. It's interesting that not uncommonly they present while on therapy, rather than just being virgin with HIV. So that's why issues with in the immune system are being investigated. I'm not going to spend too much time in hypertrophic cardiomyopathy because, again, that's a topic that we do it as a special lecture. I believe Dr. Naga covers that. We know that the most common is the asymmetric septal hypertrophy, but you can see concentric. You can see apicals, we see all frequent at times here. Mid-ventricular is exceedingly rare. And free wall, I think it's less than 1%, to be honest. With all the years we have here seeing patients with hypertrophic cardiomyopathy, I can only remember one or two. This is really probably the most rare of all. And actually so rare that if you see asymmetric free wall hypertrophy, you may think of many other things, and because there are many other infiltrated diseases and other type of genetic diseases that can do this. So you have to actually open your basket of possibilities because it's such a rare entity. And of course, the diagnosis is seeing hypertrophy on the echo and not having a distinct cause, most commonly being hypertension or aortic stenosis. And then, of course, you have infiltrative diseases like amyloid that could potentially look like a hypertrophic cardiomyopathy. The clue there being that the QRS in the EKG is usually normal or low. Sigmoid septum of the elderly, an entity that is, we see a dime a dozen. We still don't know exactly what is it. Does it have some genetic, is it a gene that makes all people respond like that? Most of those patients are hypertensive. And of course, the athlete heart that periodically can be confusing. But then, those are the common ones. Then you have a list of other more rare conditions that can kind of look like in an echo as a hypertrophic cardiomyopathy. Fabry's disease being and glycogen storage disorders being two genetic conditions. Mitochondrial myopathy also being another genetic condition. Friedreich ataxia. And then you get infiltrations and clots that at times could mimic. But those usually we can sort of work through because of the texture appearance of the myocardium, the fact that it's involving a specific area, it's not diffuse, and so on. But a lot of these other ones sometimes requires thinking about them and then doing the additional workup for each of these conditions, particularly when you don't have a clear-cut family history and things like that. Now, the obstructive one has the SAM. We've talked about that. We've shown that before. And it has the gradients. And we know that the gradient is very dynamic. And we know that some people don't have it at rest, but then they can be induced, in this case, by exercise. But quite often, Ms. Vera in the lab does some Valsalva and brings it on. So provocation is something always helpful to do when you don't have the typical SAM and obstruction at rest. And very importantly, remember that the SAM has nothing to do with the LVH. That was shown very well by the Boston group quite some time ago. And we even see acute MI patients with SAM and LVOT obstruction. So the SAM has to do more with variations in the way the mitral apparatus sits in the left ventricle. Frequently, there's an anterior displacement of the papillary muscles, elongation of the mitral leaf, particularly posterior leaflet relative to the LV size, some reduction in posterior leaflet mobility, and then a concave shape of the septum, and then the hyperdynamic base. That's where the acute MIs come in. Sometimes we have somebody that has an acute MI with a big ekinetic apex. The base is going like a gangbuster, and if these mitral apparatus abnormalities are present, that patient gets LVOT obstruction in the middle of an acute MI. And we see occasionally examples of that. So remember, it's not at all related to the severity of the hypertrophy. And of course, diastolic dysfunction is common in these patients. We all know that. And I want to show this case to you because it's a very unique patient. This is a 50-year-old man. This echo was done about 3 weeks ago with atrial fibrillation. And now watch, if you saw that echo, what would you think? So, yeah, so this septum might be a little bit more thick than the posterior wall. If you look at it in the short axis and you say, well, maybe that's a big moderator band, then you kind of get more of a concentric look. You know, and could this be a 50-year-old man with hypertension and atrial fib? Could this be a 50-year-old African-American man with hypertension and atrial fib? Yeah. We know that certain groups, particularly African-American, have a lot more genetic predisposition for concentric LVH. So this is the echo of this man 11 years ago. And actually, the first echo we have in this man was when he was 19-year-old and became my patient. Unfortunately, those are in some if they exist, they're in some old video file that I have no idea where the hell they are. And this fellow has non-obstructive HCM in a family known to have HCM. And the first time we took care of him, he was totally asymptomatic. He was 19 years old. And the only reason he was here is because his family was here with him, and his 14-year-old brother was here with him in the care of Dr. DeBakey, because his 14-year-old brother has severe dynamic LVOT obstruction, class 3 symptoms, very disabling for a 14-year-old kid. And this was back in the early 80s, or late 70s, and we didn't even have 2D echo back then. And Dr. Lowry did a wonderful myectomy, and that young man is now 44, 45, and still doing well. This fellow, unfortunately, his brother just died 2 weeks ago. Died from a bleeding, probably a bleeding ulcer that they did not catch on time, and he was on warfarin and had a massive bleed. So it's probably the longest hypertrophic cardiomyopathy patient that I have taken care of. Never, ever had any SAM. And when he was 20 years old, his septum was 4 centimeters. Unfortunately, I cannot show you that. But here we have from age 18, 19, going from 4 centimeters to probably somewhere around 2.5 here. And now, the one I showed you, we were debating whether it was thick or not. So very interesting how over progression, there's a remodeling of the ventricle. And that massive septal hypertrophy kind of got better. You know, it would be great to see if we could do something like that with MRI and have see whether cardiac mass change or whether it's a redistribution of the hypertrophy. But it's fascinating. I don't think that we have anyone else that we have taken care of such a long time. Never had any SAM arrest or provoked. We could never induce outflow obstruction. And his brother had severe outflow obstruction. And of course, apicals are always very interesting. This is a nice example. And you can see here the ventricle with the trapping of the cavity. It looks like an ace of spade. Very diagnostic when you have it. And this is just to show you that sometimes, you have a lot of attenuation and you don't see it very well. This is a great case. This is positive, but this one is another patient. Very hard to see at times. EKG, always use it as a clue because they have these very diagnostic anterior T waves. And then, of course, contrast can be very helpful. Once you use contrast, if you have a good contrast like this one, basically you see exactly the same thing that you see with a CMR. You see the hypertrophy, the apical trapping, and if you put your Doppler, you get gradients right here. So once you have the contrast, you can do a really good job. Here is an example. You can see the contrast here with the apical trapping and the apical ekinesis. And here you can see that there is all of this is ekinetic, probably from a previous apical infarct from the very high pressures these people can get at the apex. There have been demonstrations of pressures over 300 if you put a catheter in the right place at the apex. The American version tends to be relatively benign compared to the Japanese. And most of these patients are actually asymptomatic, and they overall tend to do well. As they get older, age of FIB, they can get issues, but they tend to have a more benign course. This is another example. Color was very helpful. Contrast was beautiful. And again, a short axis at the apex, you could see very nicely the reiteration of the cavity. So then we get into the infiltrations. And that's a place where really the best we can do by echo is suspect it and suggest. Because that's about it. There's nothing in an echo that will be diagnostic of any of the conditions that you see here, other than perhaps, being able to pick up on a tumor. And even the tumors, you go by the ones that are more common in terms of infiltrating the heart. But and this one does have a relatively typical feature that if you get this one with the typical features and you get a CBC, you can usually make a diagnosis right there and don't have to go beyond the echo. And they are very important because these conditions, and I know that probably Dipan would like to show this slide because this slide gets shown by everybody. But it shows basically that this type of cardiomyopathies, particularly sarcoid and amyloid, they have really bad outcomes. Most of the time they're picked up when patients already are symptomatic. Rarely do we do early detections of these conditions, and by then usually they have a relatively poor course. So early detection is very important because today there are treatments for these patients when we catch them at a more early phase. This is somebody with cardiac amyloid, but this could have been a renal failure. You know, patients with LVH and renal failure frequently have myocardium that look nice and glossy like that. There's nothing in this echo to say amyloid, other than you look at the EKG, you can hardly see a QRS. So, you know, basically having a hypertrophy that is out of proportion to your QRS voltage is the only tip-off you have for amyloid in most of these patients, unless they already have had a diagnosis by another organ, another test. They have all kinds of diastolic dysfunction, and it has been shown very well by the Cleveland group that when they change from type 1 relaxation, i.e. a low E and a high A, to a more pseudo-normal pattern, they really shift their prognosis to a really poor one. So again, ideally, you would like to catch them when they are still in that phase of only impaired relaxation, normal feeding pressures, lower E, high A, because that's the time when the most bangs for your bucks are obtained with treatment. Because the more elevation of left atrial pressures, more heart failure, hemodynamics, and symptoms, the more difficult it is to then reverse and treat and save them. And you can see how sick they can be. This patient was basically moribund. She died a day or two after we made this diagnosis. She missed the train. For 1 year, she went to 2 cardiologists with symptoms and was totally missed. By the time she came to the ER in cardiogenic shock, it was too late. There was nothing we could do for a heart like that. She was like 52 years old. Now you can see very low cardiac output. I mean, all the findings of just basically a moribund heart. Some of the prognostic markers, when you pick up elevation of troponins, very high BNPs, all of these things are telling you that there is a lot of heart failure. And of course, I know Dipan will show you some of the prognostic markers from CMR. And the name of that game is try to, if we can, pick them up early. The problem is, at the early phase, they may not have symptoms, so they don't go to the doctor. So, I mean, it's always this circle of trying to detect somebody at an earlier phase. This is somebody that you look at that echo, you don't see much to write home about. I mean, the EF looks like around 50, not the greatest. The FHU might be enlarged. But, we see echoes like this, a dozen, every day in the lab. There's nothing in this echo that would help us make any diagnosis. The only thing is that you notice is there is a very long PR interval. That could be one tip-off of what? Huh? Yeah, which one? Yeah, sarcoid. Yeah, sarcoid of all of them it's more notorious for that. Exactly. So this patient did have sarcoid, but again, nothing in that echo that would make a diagnosis. So again, there's no findings. So if you have somebody that already has sarcoid, pulmonary or whatever, then any abnormality you see, EKG, echo, or whatever, is a tip-off for having cardiac involvement. Okay? If you don't have pulmonary sarcoid, then you're of a creep, unless you're magic thinking or something else comes in. So most of the time, it's somebody that has already pulmonary sarcoid, and then you wanted to see, do they have a cardiac involvement? And so you find EKG clues, or you find some echo clues that might give you, what are those clues? You can have a little bit of lowering of EF, like this one. You can have some diastolic dysfunction. You can also have regional abnormalities. Sarcoid is one of the cardiomyopathies that can look like an OMI. They can have regional abnormalities. Therefore, maybe it's possible that strain imaging might help, because you might then have some strain curves that are really abnormal in some areas versus others, potentially. Again, if you have somebody that, or you already know they have pulmonary sarcoid, and they have a heart that is borderline looking, and you do some strain imaging, and some segments are really akinetic and others look good, that could be another tip off that you may have a cardiac involvement. Here's another patient that has a very, very bad heart, bilateral. Both ventricles are in bad shape, biatrial enlargement. Most likely this afternoon we'll see a heart like this, right? Every day from our heart failure colleagues we see a heart like this. So there's nothing in this echo, okay? So if this patient comes into your clinic with a heart somewhat like this, what should be in the list of tests that you should include in your workup? Who can tell me what should be the basic workup we do for the first time when somebody comes in with a bad-looking heart like this? Well, coronary assessment, of course. But to prevent you from saying that, I said blood work. Who said that? Okay, why? Absolutely. Ferritin should be in the pathways of any new onset cardiomyopathy. Because that's what this man has, of course. Look at that TR. Those valves don't even close each other, of course. This is a very advanced case. But this is somebody with hemochromatosis, exactly. And sure, we can do an MRI later and spend more money. But believe me, you're not going to have hemochromatosis with a normal ferritin, unless the patient have been bled for the last, But coming de novo, those ferritin levels are going to be. So that should be part of the check that you do in any workup of a new onset heart failure. So again, there's nothing in the echo. It's just thinking of it. If they have a family history, that's a slam dunk. But quite often they don't. So quite often you may be the first one to have to make diagnosis when they present. So I'm ending with this slide so that I'm the when you have concerts, you have a big band and a small band. So I'm the small band making it to Dr. Shah, so he come in and splash you all with his CMR. Oh, one last one though. This one does not need a CMR. Okay. This one I think you can do it with an echo by itself pretty well. So this is a 44-year-old lady with heart failure, and who can tell me what you think this is? I'll give you a clue. This is your best bang for your bucks, that view. Yeah, absolutely. Good deal. So what's the test you want in this one? What's the simple test you want? CBC, right. Okay. Yeah. When you have a classic case of this, you don't need a CMR. I mean, you have the clues from the appearance of what looks like a clot in an apex that frequently moves. May not move as good as this one, but rarely they are fully akinetic or aneurysmal. They have the pseudo clot looking picture, which is the involvement with the endocardial fibroblastosis, and of course the most common type will have high eosinophil count. All right, and of course these are the two kinds, the tropical, the non-tropical, and the idea being that there is a group of abnormal cells that are toxic to the endocardium, causing the thickening and fibrosis. They can also present with mitral regurg because you get then restrictive movement of the mitral valve and functional MR that can be significant at times. I don't remember when was the last time we had one. Bill, you remember? We haven't seen one of these in a while.
Last year.
We had one last year? I miss it. Yeah. I mean, usually once a year somebody comes in. Yeah. All right. So I think at this point in time we'll give it over to. I want to have Dipan have enough time to show and tell how he can help us point the diagnosis a little better in some of these cardiomyopathies.
Okay, so I think Dr. Q very nicely talked about the role of echocardiography in the assessment of cardiomyopathies. And what I'm going to touch on is the role of CMR. Now, obviously, if you look at the heart failure guidelines to Class 2A indication to move on to radionuclide ventriculography or CMR for just simply assessment of LV function and volumes when your echocardiography is suboptimal. So I think before we even talk about some of the fancy applications, just simply assessing volumes and function is potentially a role for CMR. The other aspect I think is important. When you have a patient that comes in with cardiomyopathy or with LV dysfunction, I think an important discriminating factor is whether the LV dysfunction is due to coronary disease or it's due to the absence of coronary disease. Obviously, you can see we can assess this by coronary angiography, identify a patient who's got significant lesion in his left main, or a patient who has no evidence of significant obstructive coronary disease. And then keep in mind that oftentimes you have this mixed picture where people have coronary disease or they have some coronary lesions, but again, that may not be the culprit for their LV dysfunction.
And I'm going to interrupt you for a second, because over the years, we have seen a few anecdotes that have been like, wow, because it's important we do. Most impressive anecdote was a patient of reservation, pre-coronary la carrera patient died within 2 years. Autopsy, 2 years disease, very hard to get information. And then the other one, which I think is the one more common, is what Dipan just said, that the angiogram shows one or two lesions, and you cannot explain that lesion to cause disease. But always be aware that sometimes the coronary angiogram may undercall the severity of disease and it's very, very difficult. And just like, keep that in the back of your mind. Sometimes these things don't make sense. Maybe consider doing other things. Because that second group is one that we do encounter. People have a lesion here, a lesion there, but it just doesn't account for how much muscle is happening. And maybe a little extra thinking, maybe a little vitamin stress, or something else, some study shows, wow, we have more ischemia here. So keep that in mind, that coronary angiography, although is our quote-unquote gold standard, can have people on.
That's absolutely right. Obviously, it's important because the presence of coronary diseases in patients with LV dysfunction is associated with a worse prognosis than the absence of coronary disease. So non-ischemic cardiomyopathies in general tend to do better than ischemic cardiomyopathy. So obviously, I think discriminating this, let me skip forward in the interest of time. Obviously we use coronary angiogram as kind of our gold standard in discriminating CAD versus non-CAD LV dysfunction, but CMR may actually be helpful in this role as well. And the reason for that is we know that the basic pathophysiology of ischemic heart disease is that it tends to present in this wavefront phenomenon. So it affects the subendocardium initially and then gradually progresses out to the mid-myocardium, and then eventually the injury becomes transmural. So these are some examples of coronary ischemic patterns of hyperenhancement that you can see on CMR. Here's a person who has a transmural hyperenhancement here in the anterior septal and anterior wall, and another person who has just an area of subendocardial hyperenhancement. But again, both of these patterns of enhancement would be a clue to an ischemic etiology, whereas these patterns here, where you have involvement of just the middle of the myocardium, what we call mid-wall hyperenhancement, epicardial hyperenhancement, or this kind of global subendocardial pattern of hyperenhancement. Again, all of these do not fit with what you would expect to see with injury from coronary artery disease, and these are all clues, if you see this on a CMR, that in fact the injury is due to a non-ischemic etiology. And so I'll show you an example of two patients here, patient A on the left, patient B on the right. And if we simply look at wall motion, so we look at cine CMR in both of these patients, I think we'd have a hard time identifying which is the ischemic patient and which is a non-ischemic patient. Does anybody want to tell me who thinks patient A is the one who has ischemic cardiomyopathy? Raise your hand. One person. Who think, or two people, who think patient B is the one that has ischemic cardiomyopathy? Raise your hand. 1, 2, 3 people, 4 people, 5 people. Okay. So most people are either falling asleep or abstaining.
Who don't have a clue?
Yeah. And I think most people would say it's hard to tell based on wall motion alone. But you can see in the patient on the right, when we do our delayed enhancement MRI, they're very different. The left-hand side has no hyperenhancement. the patient on the right-hand side, in fact, has a transmural hyperenhancement in the septum and anterior wall. And in fact, if we do cath, we can see this person on the left has no coronary disease. The person on the right has occluded LAD. So I think speaking to the point Dr. Q was making is that oftentimes looking at the end organ, so the coronaries show you the plumbing that gets you there. The CMR shows you what's happening at the end organ. And oftentimes having this information can also be useful because, again, we know that although we use coronary angiogram as our gold standard, it in fact does have some limitations to it. And in fact, there's several studies in the CMR literature showing if you look at patients that present with cardiomyopathy, simply by looking for the presence of an ischemic pattern of hyperenhancement, you can identify an ischemic etiology or ischemic cardiomyopathy with actually a very high level of sensitivity. So beyond patients with ischemic disease, for patients who have non-ischemic disease, I think the underlying etiology is very important because it has prognostic implications, as Dr. Q, I think, showed one of the other figures from this publication. Now, obviously, you have a potpourri of different diagnoses that it could be, and let me kind of walk you through some of these and where CMR may be helpful. So one area, and this is what we don't typically think about when we talk about cardiomyopathy, but in fact there's ARVC, right ventricular cardiomyopathy. And obviously we know that this is associated with arrhythmic consequences. And if you look at the most recent guidelines, the modified task force criteria for RV dysplasia, there's a significant role for CMR. And really recognize, though, that there's no single diagnostic criteria. Rather, it's a series of criteria that involves both clinical, family history, as well as imaging features. And you basically need to have two major criteria, or one major criteria plus two minor criteria, or four minor criteria to make the diagnosis. And where CMR can help you is that the criteria for CMR really begins with some type of abnormal contraction. So you got to have regional RV akinesis, dyskinesis, or dysynchronous RV contraction, and then couple that with either dilatation or dysfunction of the ventricle. So major criteria would be basically a RV end diastolic volume of greater than 110 index for a male, or greater than 100 for a female, or a evidence of dysfunction by an RV ejection fraction of less than 40%. So one of the things that these modified task force criteria try to do is propose quantitative criteria to prevent overcalling of this condition. And then minor criteria would be basically, again, requiring some abnormality in wall motion coupled with evidence of dilatation, but not as extreme. So in this case, a RV end diastolic index of greater than 100 for men, or greater than 90 for women, and an RV ejection fraction of between 40 and 45. So these would be the minor criteria. These would be the major criteria. And again, so remember, it's got to start with abnormality of wall motion. So, don't get too caught up in looking at volumes and EFs and things like that if you don't have abnormality in wall motion. And the criteria actually take away looking for this fatty infiltration of the myocardium, because the problem with it is that from an imaging standpoint, there's too many cases of false positives, all right? And so again, the hallmark of this has got to start with a wall motion abnormality or abnormal contractility of the right ventricle. Now let's move on to hypertrophic cardiomyopathy. Obviously, this is an apical variant of hypertrophic cardiomyopathy. We can see significant hypertrophy here in the LV apex. And in addition to that, when you do your delayed enhancement MRI, in these patients, oftentimes you'll actually find evidence of transmural enhancement in the apex. And this is really due to an apical infarct that likely occurs, again, because of a significant increase in pressure in the apex from this dynamic apical obstruction. Now, also there's the garden variety hypertrophic cardiomyopathy that again, has a predilection more for the septum, but recognize it can be concentric hypertrophy, or it can involve any of the other walls as well. One of the things that CMR helps with is not only in identifying the morphologic features, so identifying the hypertrophy, the extent of hypertrophy, but also when you do your delayed enhancement MRI, you actually see areas of hyperenhancement that don't match what you would expect to see with a coronary artery distribution. So in this patient, you can see an area of hyperenhancement here in the anteroseptum and in the infraseptum. And again, it's at the RV junction sites. It's kind of in the mid-myocardial region. And again, it'll be hard to explain a coronary artery distribution that would give you hyperenhancement patterns like this. And the presence and extent of hyperenhancement actually does seem to have prognostic value. And so this was now a large publication from the Boston group that came out a couple of years ago, where they actually looked at a large number of almost 1,500 patients with hypertrophic cardiomyopathy and found that as you have a greater and greater amount of hyperenhancement or scar within the ventricle, the prognosis here gets much worse. And so the graph I'm showing you here is the graph for freedom from sudden cardiac death. So clearly you can see those patients with more than 20% of their ventricle showing hyperenhancement having a much higher incidence of sudden death than those patients with HOCM with the absence of delayed enhancement. And then this actually, again, is just showing numerically the increasing prevalence of sudden cardiac death as you have an increasing burden of fibrosis within the myocardium. And interestingly, in this study, they also were able to demonstrate that the presence of hyperenhancement, or the extent of it, is not only associated with sudden cardiac death risk, but also with an increasing risk of end-stage HOCM, such that the cumulative risk for these patients of death is really due to a combination of both sudden cardiac death as well as end-stage HOCM, and that risk increases as the fibrosis burden within the myocardium goes up. Now here's another condition, and this is one that's not uncommon, quite honestly, and this is Takotsubo's cardiomyopathy. And so these are the Mayo Clinic proposed criteria, which is basically transient, reversible regional wall-motion abnormality of the LV extending beyond a single coronary artery distribution, the absence of obstructive coronary disease or acute plaque rupture, new changes on a electrocardiogram, and then they require some exclusion criteria such as recent head trauma, intracranial bleeding, pheochromocytoma, myocarditis, hypertrophic cardiomyopathy, and things like that. Now, this is a classic case of what we think of as that kind of that apical ballooning that occurs in Takotsubo's. But the reality is, it's actually a very nice CMR publication from a few years ago in JAMA, where this is multi-center looking at a series of almost 200 patients that presented with suspected hypertrophic cardiomyopathy. And what they found, in fact, was that although the most common pattern was this apical ballooning, which occurred in about over 80% of patients, in fact, in about 17% of patients, you find mid-wall ballooning, as you can see here. In a very small percentage, 1%, you actually can get basal or inverted ballooning, as they refer to it. And then, interestingly, in about a third of these cases, there was actually evidence of some ballooning of the right ventricle as well. So again, this is a condition that may not affect just the LV, but you may again see an effect on the right ventricle. And again, the underlying pathophysiology here is not well understood, and I think we're still learning from it.
I want to challenge one of the criteria, because certainly the last one you show on your right, probably we would have trouble with echo, seeing the ballooning of the LV. But the one that's 32% common and the one that is 1% common, those two actually follow distributions of blood vessels. It's the middle one, the only one that you can truly say that it does not follow distribution of blood vessels. So to me, that thing of not following distribution of blood vessels, I think it's overdone. Because the most common type is looks like
the
an
apical.
And in fact,
Right.
most of the time, that's what happens. They come into the cath lab and they're taking the cath lab because everything looks like an LAD infarct and they have no coronaries and then we diagnose it. And luckily, most of them get better. But I think they have overdone this concept of not being a distribution of blood vessels. I would like to challenge that. I think that could create confusion in people because the most common type actually looks like an LAD and the least common looks like an RCA. It's really the one in the base that you can truly say, oh, wow, this is unique. You know. There's no blood vessel that will do that.
Yeah, I agree with you. I think probably the only clue for the these are the proposed criteria. No, I agree. The only clue here would be the fact that it extends up a fair bit into the lateral wall, which oftentimes with the LED. But again, I mean, you're right. There can be a lot of variance in anatomy. Yep.
That's just way overgrown.
So the other thing that they found in these patients with Takotsubo's by CMR is interestingly that there really isn't any evidence of significant hyperenhancement in these patients. So especially if you use a threshold of 5 standard deviation above remote or normal areas, there's really no detectable hyperenhancement in these patients. Yeah, so there's different criteria. So that's actually a commonly used criteria for identifying non-ischemic patterns of enhancement. Pardon me? Yes, exactly. But again, this is 5 standard deviations above a remote region. Remote region should be black, so what you're trying to do is just filter out the noise. So basically, the standard deviation in a remote region, which is black, is basically the amount of noise that there is. So what they found in these Takotsubo's patients in this study, obviously, is that most of these patients had a significant increase in LV ejection fraction at follow-up, and also a decrease in LV end-diastolic volume. So basically, you got favorable remodeling that occurs, and we know that's one of the hallmarks of Takotsubo's, is that there's reversibility and a high likelihood of resolution of the abnormality. Now, let's move on to another condition. And interestingly, this is one condition that for some reason seems to be much more prevalent in Germany than in the U.S. Because we see this, but not nearly to the extent that the Germans report on, which is myocarditis. And so this now is a study that's about 10 years old from a German group, where what I think what's unique about this study is that they took patients that presented with suspected myocarditis and did delayed enhancement CMR on them, but then based on where hyperenhancement was evident, they actually went and did a biopsy in the left ventricle to try to biopsy the area where there's hyperenhancement present. And when they did that, they found, in fact, that in 90% of cases, they were able to identify the evidence of active virus, with parvovirus B19 being the most common, present in over 2/3 of cases, and in about 1/4 of cases, herpes virus type 6. And in about 10% of the patients, the biopsy turned out to be negative, despite having evidence of hyperenhancement on the CMR. So again, I think that provided at least some pathophysiologic data that suggests that when you see these hyperenhancement patterns, they are truly indicative of active myocardial injury. And then that same group did a subsequent study where they looked at outcomes in these patients. So patients presenting with suspected myocarditis, if they have evidence of hyperenhancement, they have a much worse prognosis, whether you look at all-cause death, if you look at cardiac death, which is in the middle, or you look at the incidence of sudden cardiac death. You can see that patients without hyperenhancement have a much better prognosis than patients with evidence of hyperenhancement by CMR.
Patients without hyperenhancement have myocarditis?
Well, no, these are patients that presented with suspected myocarditis. So we would say by CMR that these people didn't have myocarditis. And in fact, you can see in those patients the prognosis is much better than patients who by CMR you would say do have evidence of myocarditis. So here's another condition. And I think if I show you the cine MRI, most of you would say yes. I think there's definitely pericardial effusion. There's LV hypertrophy, and in fact we measure a wall thickness of about 1.6 centimeters. There's in fact some RV hypertrophy as well, measuring RV wall thickness of about 8 millimeters. There's biatrial enlargement if you look at this long axis view down here. EF is mildly depressed, 47% is what we calculated. RV-EF also is a little bit down at 38%, and then LV mass is increased. But I think simply looking at this alone, as Dr. Q, I think, pointed out with the echoes, I think our level of diagnostic certainty as to what the diagnosis is not going to be that high. Could this just be a renal failure patient? Could this be a poorly controlled hypertensive patient? There's a lot of different things that this could be. Now, obviously, if I show you the delayed enhancement MRI findings, I think our level of certainty goes up quite a bit. What do we see here? So we see basically very diffuse pattern of global hyperenhancement. What's interesting is not only is it affecting the left ventricle, also is affecting the right ventricle as well. And if you look at these long axis views, You can see hyperenhancement in the atria also. And again, this is really the hallmark of amyloid heart disease, is when you see this diffuse pattern of hyperenhancement on your late ganglion enhancement CMR.
So now that we are treating some of these patients with our heart failure group,
Yeah.
I'm hoping that all of them are passing through this.
Yeah.
Okay. Do we have?
Yeah. I'm not sure that we're systematically doing
Well,
that.
no, because we really
Yeah.
should. So the question is, can we eventually determine a certain quantitative level of infiltration that the medication basically won't work?
Yeah.
And therefore, why subject the patient to all of that? You know, to me, that's a critical question. Because these patients now are coming, they're being referred, you know, they're going into very expensive and potentially toxic drugs, trying to get them better. And if we have an opportunity now to potentially be able to find a threshold, that you could say, you know what, none of these patients have more than
Yeah, so there's actually...
Let's do a plan B.
There's actually a multi-center study that we're involved with the heart failure folks, which is looking at a novel therapy, and in that they're using CMR at baseline, as well as actually trying to use CMR to look to see if there's changes that happen with therapy.
That can be reversed. That would be fantastic.
Right, and the answer is, there's really not much in the literature to know what are the changes in these findings over time. So I think this is, this multi-center study that we're involved with, I think will hopefully try to help address that question, but we don't know yet. What we do know is that pattern of enhancement clearly is associated with a worse prognosis. So if you look on the left-hand side, this was a single-center study where they looked at patients, again, with evidence of biopsy-proven amyloid by somewhere in the body. So typically it's by fat pad. And then they put these patients through CMR scans, and what they find is that those patients who don't have any evidence of cardiac involvement based on this late gadolinium enhancement, the prognosis in these patients is much better than patients who have any evidence of late gadolinium enhancement on the CMR. And in fact, if you use CMR as your discriminating factor to say yes, cardiac involvement or not, it's actually better of a prognosticator than New York Heart Association class. You can see here in patients who have biopsy-proven amyloid somewhere else outside of the heart, if you have New York Heart Association class 1, you still have a pretty bad prognosis. Obviously, if you have class 2, 3, or 4, prognosis is worse. But again, CMR proved to be a better discriminator in this study. Again, that was a single-center study, and then we followed that up with a multi-center study where we again showed a very same finding, which is that if you have evidence of hyperenhancement, and especially if you have evidence of the diffuse hyperenhancement that I showed you, your prognosis is much worse than if you don't have evidence of that on the CMR scan. Now, this is a study looking at sarcoidosis. And again, sarcoid is one of these great masqueraders because it can really give you a variety of different hyperenhancement patterns. Here's an example of somebody who has a subendocardial hyperenhancement pattern, which could look like a subendocardial MI. Here's a patient who has a transmural hyperenhancement, but notice the clue is there's this other little patch of enhancement over here. Here's somebody with mid-wall enhancement. Here's somebody with epicardial enhancement in the LV, but also affecting the RV as well. And here's somebody who has kind of multiple patchy foci of hyperenhancement. So sarcoid really can give you a variety of different hyperenhancement patterns. Now with CMR, one of the ways that we can identify this is obviously if you have somebody who has known pulmonary sarcoidosis and you're trying to see if there's evidence of cardiac involvement, CMR can be useful in that setting. Oftentimes, though, what we get is we get patients that get referred for assessment of heart failure or cardiomyopathy, or sometimes just an assessment of arrhythmias, and we find evidence of substrate, and then also when you look at your images through the chest, you can see, as I'm showing you here, evidence of extensive adenopathy. And so that's one of the clues. Oftentimes, the diagnosis of sarcoid is first suspected at the time of the CMR lab. And what's interesting is in this study here, this came out about 6 years ago, they looked at a cohort of about 100 patients with known extracardiac sarcoidosis, and using the Japanese Ministry of Health criteria, they would have suspected cardiac involvement in just a little over 10% of patients. But by CMR, there's evidence of hyperenhancement that's present actually in about a quarter of these patients. And what's interesting is that the CMR was the best prognosticator in the sense that if you have no evidence of hyperenhancement on your CMR, your prognosis is much better than those patients who have extracardiac sarcoid and evidence of hyperenhancement. And again, this is looking at a composite endpoint. which included both mortality as well as symptomatic brady or tachyarrhythmias. Or if you simply look at mortality alone, you can see again that CMR provides a pretty good discrimination between those patients who have a good outcome and those patients who have a poor outcome. So here's another condition, and I think most people looking at this would say right off the bat, this looks pretty easy to identify. I see prominent trabeculations here in the LV apex, both on my short axis as well as on my long axis views. And obviously this is a condition of, or this is a case of LV non-compaction associated with LV dilatation as well as LV dysfunction. And the criteria that we use in CMR is based on this publication from Peterson and colleagues, which basically looked at the ratio of non-compacted to compacted myocardium in the ventricle during diastole, and they use a cutoff of greater than 2.3 to 1 to be the one that best discriminated patients with non-compaction compared to patients with other conditions that may cause prominent trabeculations as well. So again, these criteria are a little bit different than the echo criteria, which are done in systole. These measures are done in diastole. Iron overload, this actually highlights the use of this T2 star imaging technique by CMR, which allows us to basically quantify the extent of iron that's present within the myocardium. And iron basically leads to a shortening of the T2 star time. So as there's more iron content, you're going to have a shorter and shorter T2 star value. And for the heart, T2 star values of less than 10 are considered diagnostic, 10 milliseconds are considered diagnostic of iron overload, and greater than 20 are considered normal, and then between 10 and 20 is kind of a gray zone. And what's interesting is, this technique was first developed in the UK, and when they began applying this technique in the late 90s, early 2000s, they saw really a significant reduction in the incidence of iron overload death in thalassemia patients in the decade following the advent of this technology. And in fact, in this publication, they highlight the fact that there was a gradual increasing over the years in the incidence of iron overload death in thalassemia patients, and then with the advent of this technique, a significant reduction in cardiac death in these patients. Again, highlighting the fact that imaging may not only be useful in identifying the etiology, but actually may be helpful in management and in potentially improving outcomes.
So leave that slide for a second, because that's very interesting. So the question here comes in now. The hypothesis is we are detecting it earlier, we are intervening aggressively, and we are holding back the progression.
Correct.
My question is, has there been any publication actually showing regression? Can you actually get rid of some of that?
Yes.
That gadolinium you
No, so in this case, so remember, this technique, this is not a gadolinium-based technique. This is just a non-contrast-based technique that measures T2 star values. Good. But yes, what they use is, when you're doing ion chelation therapy in these patients, is you track to see that the T2 star values improve.
So they do improve.
So they do improve. The challenge becomes that the liver values improve first before the heart values do. And so before this technique came along, you got it right, exactly. So you have to know how much to keep doing it. So iron assessment in the liver has been around for some time, but in the heart only really came around in the late 90s. Yeah. And so the problem before was you could say, okay, the liver's better. Do I stop or do I keep going? You don't know, because you don't know if the heart's improved or not. Good. And this allowed you to track the iron load within the heart itself. And the last condition, I think, obviously this is right now probably the most common form of non-ischemic cardiomyopathy, which is idiopathic dilated cardiomyopathy. And this was now a very nice publication from Galati and colleagues in JAMA a couple of years ago, showing if you look at those patients who have, again, that mid-wall hyperenhancement that you see in idiopathic non-ischemic cardiomyopathy, the prognosis for those patients who have mid-wall enhancement is much worse than for patients who don't have mid-wall hyperenhancement. And that's whether you look at all-cause mortality or you look specifically at cardiovascular mortality or transplantation. And in this study, they also had a small group of patients where they actually had autopsy hearts. So some of these were patients that died after the CMR, or some of them were patients that went on to get a transplant. And they show, in fact, that there's a pretty nice correlation between what you see histopathologically and what you see is hyperenhancement on the CMR scan. And so again, if you have an idiopathic cardiomyopathy and you have evidence of hyperenhancement, you have a worse prognosis than if you have idiopathic cardiomyopathy with no evidence of delayed hyperenhancement. And then they also showed not only at survival, but also at the incidence of sudden cardiac death and aborted sudden cardiac death was much higher in idiopathic patients with evidence of fibrosis by CMR. And this now is a meta-analysis looking at several different studies over the last 15 years or so in patients with non-ischemic cardiomyopathy. Again, have consistency, which is that the presence of hyperenhancement is associated with the worst outcome. So I think somebody's telling me to finish up here, so let me wrap up here by this little cartoon, which shows, again, the differing patterns of enhancement that you see. On the left-hand side, what you see with ischemic injury. On the right-hand side, patterns that you can see with non-ischemic injury. And again, some of the potential etiologies of cardiomyopathy that may cause this. Obviously, amyloidosis is the one that most commonly causes this global pattern of hyperenhancement. Sarcoid, as well as myocarditis or Chagas disease or Anderson Fabry disease, oftentimes causes this epicardial pattern. We know that hypertrophic cardiomyopathy tends to have a predilection for the septum, and then idiopathic cardiomyopathy or myocarditis tends to cause this mid-wall pattern of hyperenhancement. So to wrap up, I think where CMR is useful is not only in identifying the morphology of the ventricle and the ejection fraction, in helping to discriminate between ischemic and non-ischemic etiology, but really identifying that substrate within the myocardium that may help you to identify the etiology of the heart failure based on the patterns of hyperenhancement, and I think most importantly helps to identify prognosis in patients with cardiomyopathies. So, question, Eric?
Yeah. So, when you talk about non-ischemic dilated cardiomyopathy, I'm thinking of the global process. Why is there focal areas of hyperenhancement
Yes.
along the septum?
Yes, that's a great question. So the likelihood, there's a variety of different hypotheses as to why this is. One of the things I think I showed you earlier was that myocarditis, if you look at what is the location of injury that tends to occur in myocarditis, one form tends to give you epicardial enhancement in the lateral wall, one form tends to give you mid-wall enhancement. So the question is, are some of these actually patients who had old myocarditis in the past? So that's one possibility. The other thing is that even in patients who have idiopathic, myopathy that's more diffuse in nature, there's probably some regional variation in the deposition of fibrosis. And as a result, for whatever reason, it tends to have more of a predilection for that septal region. So the reality is you can see, that mid-wall stripe that I showed you is not the only pattern that you'll see in idiopathic, but that's the most common.
Is there a hypothesis which has been known for years, before we haven't had a biopsy, is that in non-ischemic cardiomyopathy, you may see perivascular fibrosis, and areas of microvasculature clots. So again, you could also have diffuse microinfarct in not by traditional cardiology. So there are all kinds of different hypotheses.
Yeah, and one of the things I didn't show here is if you look at several CMR studies looking at non-ischemic patients without coronary disease, thought to be non-ischemic cardiomyopathy, between 10 and 15% of them will have evidence of CAD pattern enhancement. So these are people that probably had an MI at some point in the past, but when you do the cath at the time, either the lesion's gone or the vessel's recanalized or whatever. And actually, that's not unique to CMR. There's also autopsy data. Some study of the Atlas trial, when they looked at autopsy hearts in non-ischemic, they also found the same thing. About 10 to 15% of the time, you actually have evidence of myocardial infarction in patients who have no other evidence of coronary disease.
In the previous slide, it's interesting. You had in the list of differential was cardiac transplantation. What are those usually?
Those are the very end-stage transplant vasculopathy cases. Yeah. Thought to be due to transplant vasculopathy. Yeah, that's one that's quite honestly not that commonly seen. Yeah. I mean, the most common, if you see that, it's almost going to be amyloid. Any other comments or questions? Okay, well, thank you all for your attention.
Good job, man.